Today, we're going to be doing some CPD, which is very, very relevant to all of our practices. I'm joined by Mr. Bob Chatterjee, who is, as you can see, the Chief of Spinal Surgery at St. John and Elizabeth's Hospital. He's also the President of the Royal Society of Orthopaedics, a reviewer for the Journal of Bone and Joint Surgery, and he edits Spinal News. Bob, welcome to the Academy. Do you have time for anything else after all those things?
Very little. I think sometimes my family wonder where on earth I've gone.
Well, I have to say, I mean, it's very kind of you to give up your time to be with us, and you know, you're not only all those things, but you lecture internationally as well. And perhaps you could give us a little bit of background on yourself, because you've done so much training and you take part in so many different things that I couldn't remember them all.
No, yes, of course. Well, I originally trained as an orthopaedic surgeon, but as I was sort of going through my training, spinal surgery itself was changing somewhat, and it became apparent really that traditionally, spinal surgeons come from two branches. Some of us come from an orthopaedic background and some of us come from a neurosurgical background. But particularly in the last 10 years or so, people have felt really, if you're going to do spines, it should be your sole practice and you should really come, educated from both disciplines. And so unfortunately, after we've finished orthopaedics or after you finish neurosurgery, you then have to switch over and do the other one. So it's rather a long time at school. So I certainly don't accept any complaints from my children when they complain about their homework. So it's a long training period, but the spines is my passion. It's the only thing I've done in the NHS throughout my consult practice, the only thing I do in private practice. And I spend a lot of time actually traveling around the world, looking at spines done in different places, from sort of Africa, India, China, and so forth. And you always find that you've got a lot to learn from different cultures and different ways of doing things. So it's absolutely my passion, and it's my pleasure to be here with you today, because teaching is a really big thing of mine.
Thank you. I mean, one thing that occurs to me is that a lot of us will probably be a little bit unclear about what the difference is between neurospinal surgery and orthopedic spinal surgery.
So in the old days, orthopedic spinal surgeons used to do the back, and they would do everything to do with the back in terms of bones and nerves and so forth. And neurosurgeons tended to do the sort of brain and neck area and they sort of meet halfway in the middle. Those are the sort of traditional routes, but through the different types of training, if you like, orthopedic surgeons tend to know a bit more about bone. So had you had an accident, for example, and damaged your spine and you need to reconstruct it, there'd be an awful lot of useful information from there. But equally, neurosurgeons would know how to deal with nerves better. So when you've got problems with the nerves of the spinal cord, that's absolutely their field and what they're used to dealing with. And that's really why I think, as a group of spinal specialists, we came to the agreement that really we should be doing both if you want to specialize in spines. So these days, most of us who are coming through in the last decade or so are duly trained.
Right, I see. So we've got a slide here which tells us what you're going to be covering today, which I think, when I looked through your slides, I mean, I thought it looked particularly interesting. There's a lot of stuff in there which ought to be revision for all of us, but that's never wasted. But also some nice little horror stories that hopefully we can avoid in the future.
Yes, I wanted to talk about a few things, really. I suppose this is less of a lecture, maybe, and more a bit of a sort of a telling of a journey of mine through spines. When you start off in spines, you sadly think you know it all, and as years pass by, you realise you know hardly any of it. And in all practice, I'm afraid we, in a sad sense, we tend to learn a lot from the mistakes we see and come across and even make at times. And so I really wanted to share some of the experiences. That's the only way you really learn. So I just wanted to give you a sort of unfiltered view of my sort of 15-year career in spines and what I've learned in it.
Right. Okay, so I guess we're going to start with basic principles then, which and this slide sort of kind of tells us what you want to cover there.
So with basic principles, when I teach my students, it always comes down to the first few things, because they're all desperately keen on what I call the fascinating new technology, the imaging and so forth. And when you come out, you're as keen as mustard. Of course, you've learned all these skills during your surgical training, and you're desperate to let loose on somebody or something. But you find, as I've gone through the years, and I do a fair amount of sort of medical legal cases and second opinion cases, usually it's not that the surgeon has necessarily made a total hash of what he or she has done in terms of their operation. It's more that they've never really understood what the problem was in the first place. So it always goes back to your first principles, that get your detective work right. If you understand the cause of the problem, the rest of it in some ways gets a lot easier. It's usually the failure of diagnosis that's the thing that I tend to come across.
You make it sound as though understanding the cause of the problem is dead straightforward.
No, it isn't, and that's the thing. It needs quite a lot of work and effort, and often I find that not enough effort is put towards that. More effort is done into sort of, well, we can do fancy operations doing this or that, and it doesn't matter how fancy they are. It won't matter a jot unless you haven't, if you haven't understood the cause of the problem. So I always say that the three basic things really are history, examination, and imaging. And the most important one of that is history, still, despite all the fancy technology that we have. I actually generally think probably the audience who are listening today are probably better at this than we are as surgeons. I got to be honest, and most of my colleagues aren't necessarily people surgeons, if you like. They're sort of very into the sort of technology and the operations and so forth. But actually, you need to be a people person to understand spines. And there are a few pointers that I tend to tell people when going through their history. It's not just about, what's kind of got you, why you're here today. You need to understand their whole journey. I just saw a patient literally before I started this lecture today, and his problem started 18 years ago, and you need to go back 18 years ago, okay? You need to understand what was the first thing, because often you find that small things snowball into big things. Little misconceptions or misinterpretations, give patients often the wrong ideas, and you need to understand their understanding of their own condition, because you've got to empower them. So you want to really know whether, where has this problem come from? Is this a problem that's, if you like, the sort of the end of a long process of degeneration? Is this a blip that they've actually been managing perfectly okay? You need to understand a bit of their journey. One of the other things you need to understand.
Is this still a problem perhaps in your world? Do you think that surgeons perhaps don't do this as well as they should?
Definitely. I mean, it's partly understandable. If I can speak from my NHS experiences, you have a very small amount of time per patient. I think when I first came as a consultant, I think I was given about 7.5 minutes per patient. And I mean, if anyone can get a detailed history in that time, well, my hat's off to them. I certainly can't. I tend to find on average for a new patient, it's somewhere between half an hour to an hour, in all honesty, because the problems are complicated. And as I said, not all surgeons are great sort of talkers and have the time and care to talk to people. But I do think that that's where the biggest problem is. It's not technical ability, it's lack of understanding of people and their problems.
Well, we've already had a question come in about history taking. Caroline has asked whether you could tell us whether you take a stress inventory as part of your case history.
Completely. So you need to understand what triggers their symptoms. So we tend to talk about the 5 things. We say marriage, divorce, changing jobs, exams, and moving house, just as an example of 5 factors that you should look at that often people will exacerbate the symptoms they often have. And that's a critical part, because they may come in absolute agony, but you need to differentiate that. How much of that is because of the current stresses that are going on in their lives, and how much of that is pathology? Because getting rid of stress, you can do that without doing an intervention, if you like. You just talk to them, or psychology, or whatever you want to do. If you get rid of the stress, you might find that their symptoms actually settle to a great deal, and actually they don't need anything interventional.
Yeah.
What brought them to seek attention? If I can just focus on that a little bit. So I call them hidden anxieties. Don't assume the patient will always tell you why they're here. Sometimes it's couched in languages. I had a lady the other day who was sort of telling me about her symptoms, but something wasn't quite right. I was thinking, well, I sort of know what you're telling me, but why are you here? And then suddenly, after talking to her for a few minutes, it became apparent her sister had died of cancer, and it hadn't been spotted, and it had started out as a problem of the back. You're only going to get that sort of thing on a detailed history, but if you don't understand that that was one of the trigger points for her to come and visit you in the first place today, then you won't be addressing her concerns. And that's absolutely critical. Don't just address the MRI scan. You need to address the patient's problems as they experience it and as they describe it. So just be aware that they won't necessarily volunteer it. Sometimes you've got to drag it out of them a little bit. I talk about their objectives, and one of the things that, one of the specialties I suppose I'm particularly interested in is older people. So older people's spinal sort of problems and surgery is my particular specialty, because I remember I did a job some years ago where I felt they were very much just fobbed off really on the grounds of, well, you're sort of 65, what do you expect? Or, off you go. And it's not like that at all. And you shouldn't assume that 2 75-year-olds are the same. I can show you one who's extremely active and is fitter than me, and I can show you one who's who's on triple option, has had a triple bypass or something. So they're not all the same. Don't try not to bring the age into it. And I think that what you need to understand is, what do they want? Where do they need to get to? You need to understand their objectives. So it's a big difference. If someone tells me that they want to run, and that's a big thing for them, then I know and I understand what they need to do. If someone else tells me that actually they're not particularly sporty, they just want to walk more, you've got to understand these different goals, because you need to feed that back into your thinking process in terms of when you're deciding what it is that you'd like to do. So understanding where they want to get to is as important as understanding where they come from. Now, I've put down there, explore incorrect understandings. So you have to develop a rapport with your patient, and often they'll have a very different idea of something from you have. And what you've got to try and do is sort of understand that medical language is often complicated and not well understood, and it's a good idea not to speak in it. So I try to really speak in as plain English as I can. What you're trying to convey is information. At the end of the day, my job as a doctor or surgeon is to give patients information so they can decide what they want to do with themselves and their condition. To giving them medical gobbledygook gets them absolutely nowhere. Now, the internet, unfortunately, sometimes helps and sometimes doesn't. So for as many good sites with good quality information, I see quite a bit of scaremongering, particularly the American sites. I mean, I have to say, I think a lot of them are somewhat commercially guided, and that's a big no-no in my book. So it is worth understanding what they understand by their condition. So sometimes a person will come in. I had one today who said to me, I've got problems at L45. Oh, what does that mean? I don't even know what symptoms you're talking about. That sounds to me like you've been reading too much about something or somewhere. So try to demystify it all, if you like, and get down and speak in plain language that everyone can understand, and get an idea of their understanding of it all.
How do you cope with the patient who comes in and says, well, I've read on the internet about this, I think I've got this condition and I need an MRI, and you say, well, actually, the probability, the possibility is very, very low that you've got that. But they say, well, I don't care. There's a possibility. I want the MRI, or I want this surgery, or whatever.
So I've dealt with it in different ways. When I was on the NHS, I'm afraid I didn't have any choice, because there are strict guidelines and criteria. And if you don't fit the criteria, you're not going to get an MRI scan. Privately, I almost always offer them an MRI scan. My rationale for this really is that sometimes when patients have got that idea in their head, whether the idea is incorrect or not almost doesn't matter. Until you satisfy that idea, you're not actually going to be able to move forward. So many times on the private side, I've done an MRI scan in my head thinking, I know this is going to be okay and they don't really need it, but they feel they need it, and it's a block to them moving on, because no matter what other ideas I'd introduce, they'd be like, yeah, but you don't know because you haven't had an MRI scan or something like that. So I have a fairly low threshold for giving patients what they want on the private side, because I think that actually you need to treat their psychology as well as their pathology.
Do you have the same approach when it comes to actual surgery? And you might say, well, there's a such and such a percentage of success with this surgery, and they say, well, I definitely want this because it's definitely going to fix me.
Yeah, it does come into it a little bit. Sometimes in the other way, though. So, for example, I've seen colleagues before make good cases for surgery, where if you looked at the scan, you think, yeah, that's reasonable. If you looked at their neurology, you might think that's reasonable. And then you meet the patient and they don't want it, or they're terrified of it. And then the first thing you think is, no, don't do it. Try very, very, very hard not to go against patients' beliefs, because I can't prove it to you scientifically, but over the years, I'll tell you that if someone has made a clear decision that they want particular surgery and you think it's reasonable, then they tend to do well from it. Even if I think it's reasonable as a surgeon, even if I think it's the best thing for them, and even if I think it'll do them all the good in the world, if they don't want it, they usually don't come out with a good result, no matter how well you've technically done the operation. So I think the patient's mentality has got an awful lot to do with their outcome, even though it isn't really there in the books and the papers. It's true to say sometimes that if patients want surgery, they tend to do very well from it. But you just got to be a bit careful here, because I still think that if you're going to do surgery, that there has to be treatable, correctable pathology with a good amount of evidence base behind it, suggests that the operation is a decent thing to do. But yes, I always feel that doctors used to be somewhat paternalistic. You should have this and you shouldn't have done that. And I think that's all old hat, to be honest. I think these days it's much more about what the patients want. And to some extent, provided I think an operation is reasonable, I will offer it to them. And if that's what they would prefer, then I don't really have a problem with that.
We discussed on a different show, actually, that there's some good evidence, isn't there, that people who were expecting knee surgery, if they had the incision and the incision was immediately sewn up, a lot of them tended to do just as well as those who'd had the real operation.
Absolutely. I just can't
do that. You could do that to your patients without their knowledge, obviously. But
no, I agree with that.
I like the medical terminology in your last point here. Beware of nutters.
No, what I meant by that is that over the years, actually, so sometimes you're gonna get difficult patients some days, and some days you get patients who you just can't make head or tail of, and they have no symptoms that make any sense to you. I'd just say beware of these patients. Normally, when you see a patient in any of your clinics, you'll talk to them, and what they tell you is a very good guide as to what their problems are or aren't. But when you get people who can't give you a coherent history, or some people, for example, who've got other medical conditions like dementia and so forth, and can't explain themselves to you, what you then have is you've got a situation where you've actually got less information to go on than you would normally have got from history. And in those situations, you need to cast your net a bit wider because you don't have the history to help sift through the possible diagnoses of what you have. So in these situations, actually be more suspicious and so don't sort of dismiss them. Actually take it more seriously. I've had some weird and wonderful things over the years. I mean, I remember a poor patient who was stuck in a hospital in North London on the NHS for a while, complaining of something dancing along her spine and her neck, and everyone thought it was complete nonsense and made absolutely no sense. No one could find any obvious neurology. Some well-meaning junior doctor thought, well, we better just scan it, and found a tumour. Had absolutely no symptoms consistent with anything, no history, none of the textbook signs were all there. And again, the history was misleading. So I just say that you'll all get these patients at times which exasperate you. Don't dismiss them. Sometimes they will have things wrong with them. They just can't convey it to you.
Right. And does that lead on into the sort of worrying patient profile that you've talked about here?
Yeah.
Then?
So these are some of the patient profiles that when I see them, I realize that actually that I can't tell so easily whether there's anything significantly wrong with them or not. And there are a few things. So, it's well known that depression, there's good evidence that when a patient's depressed, that is a negative factor in terms of their symptoms. So again, you need to know about that. When they have pain and suffering, what's disproportionate, as I say. So for example, you may look at the pictures and the scans don't look that bad, but their symptoms are terrible. I think as someone was mentioning earlier, you need to see, well, what other factors might be exacerbating those symptoms? Are there any other stress factors that might be contributing to the symptoms they have? I'm always a bit worried when people have an overuse of prescribed analgesics. I've had people come in with their own pharmacies before, and that's a bit of a worrying sign, because the vast majority of people actually want to get better without medicines if they possibly can.
Is it just inappropriate use, or are people often kept on them for longer? Or is this what you mean? They're kept on them for longer than they need by their GP, who just keeps offering the repeat prescriptions?
Yeah, I think, to me, it's a bit of laziness, really, on honesty. I don't like people on repeat prescriptions, because I just think, for most people, what you really should be looking for is a long-term, non-medicinal, non-interventional, self-supported solution. That's really what you're looking for. You should not be trying to put drugs in your body as a long-term solution. Short-term, fair enough. If you're an agony, of course, I'm not saying you shouldn't be without analgesia. By all means, get over. But these repeat prescriptions, I suppose my criticism would be that there seems to be a lack of thought process. What is the plan here if you're giving someone a repeat prescription of analgesics ad nauseam? Are you just planning to do this for the next 20 years of their lives? You're going to run into other troubles with them. So I want a clear reason and a thought process as to why an analgesic is prescribed, which one, what are you treating, and how long are you treating for. So I'm afraid I'm not a great fan when I see people with boxes and boxes of analgesia.
Yeah, this is an interesting one. This superstitious beliefs about bodily functions.
Yeah, it's an interesting one. I've had people from all parts of the world, as I said before, when I've travelled around, and I've found ideas that people have about their bodily functions. So I had a gentleman in just a few months ago who was explaining that he could alter all his bodily functions due to the amount of sunlight he was going to be receiving. and therefore he was exposing parts of his back to sunlight disproportionately by covering up other areas in the view that this would cure his problems. I had people who were injecting themselves with part of their own muscle tissues from their quadriceps. They jabbed themselves with a quadriceps, removed some what they thought was muscle tissue and inject it into areas that were weak. You get some really weird and wonderful things. They don't always volunteer it because I think that sometimes they realize it's a little bit cuckoo. But again, you just need to again on the questioning, just to ask them, well, what do you do? You know, how do you manage your symptoms? And if you're nice and friendly enough, they'll often open up and tell you a bit about it. It's not that common a thing, but I've certainly seen a few over the years. But yeah,
how did you fare trying to talk someone out of injecting their quadriceps into wherever their problem was?
So I don't start by telling them that it's rubbish or nonsense, because if you start talking to them in a condescending manner, people just don't respond. And what I normally say to them is I'll say that that's not a technique that I understand and recognize, although I'm not claiming that I understand and recognize every single technique in the world. But I would say that the reason you're here is that technique probably isn't working for you, otherwise you probably wouldn't have come to see me. So why don't we try something different? And I'll probably steer the conversation in that direction.
Yeah.
And failure to work or perform expected activities. So it's a pretty big thing about people wanting to work. I always have that story I tell about the chef who chopped his finger off, and when I told him it was really good news that his tendon wasn't completely severed and he'd be all right, he was extremely disappointed because this means he wasn't going to get his compensation payment from his workplace. So you do find these weird ones. So I often do ask, there's evidence to suggest that if there's compensation and litigation involved, there is almost an incentive not to do so well. So you should just explore that. So I've seen people often who come for sort of medical reports, after various accidents, and I'd like to know, what do they want to get to? It ties in a bit to their objectives, whether they want to go back to work, or whether they're more than happy sort of in an illness or sickness role. So it's just a thing to pick up in the history.
Bob Javon has asked a question about your first point. She was taught there's only a small correlation between physical damage of a structure and pain levels, asymptomatic disc herniation, for example, and she seems to feel that you disagree with that idea. No,
I agree with that. I was saying that, do you remember I was saying that often you're going to get a disproportionate amount of symptoms from the pathologist. So that what I was saying is when you see something, for example, it looks small on the disc. I'm not saying that it's impossible that might be all responsible for symptoms, but often there's other factors there that might be contributing to the symptoms. So I'm just saying that when you see something, when you think, well, it doesn't look that bad on the scan, but it looks worse on the patient, you're right to say that it might be the pathology. There isn't always it's not always the case that the bigger the disc looks on the scan, for example, the worse the pain is. That isn't a correlation that's there. But you shouldn't just automatically assume that it's definitely due to that. You should look for other causes as well.
Right. So what about abnormal psychometrics, like the image in the corner there?
I think that was the Beatles. I think Beatlemania. I think, no. I sort of, this was just really a sort of a follow-on from the previous sort of slide, really, to say that in terms of the evidence-based literature, these are the things that have been sort of brought out in the literature, suggest that there is a definite correlation between these components in their history, and that predicts whether they will actually do well or not with surgery. The idea was if you have any of these particular 6 factors, your surgical outcome is less. Now, if I could just go into a little bit more detail there. So when you read a paper, it all sounds very straightforward, but if I could just take one, depression, right in the middle of that needs a little bit more investigation. So there's a great difference between depression because, you've had an injury and you've lost your job. I'd be depressed if that happened. That's what I call reactive and normal depression, if you like. So there's a great difference between that and someone who's been, had depression for 30 years for other reasons and has been on long-term medication. So again, just look into it a little bit more detail. Why are they depressed and how long has it been there for? Anxiety. I treat a lot of patients with anxiety, and you can't just dismiss just because they're anxious doesn't mean their symptoms aren't real. Their symptoms may well be real. It just means that they don't tend to do as well with surgery. So what it means to me, it's not that I wouldn't operate on someone, because at the end of the day, if they've got the pathology and they've got the symptoms and signs that goes with it, then an operation is reasonable. But I would with all surgery is very rarely black and white. It's usually a grey area in your head. You could kind of, go one way or the other depending on what you think. So when you have anxiety, it makes me a little less sort of keen to operate it, if I could put it like that. So these are factors that go into the decision-making pot.
Okay. But at last we get to examination.
So this talk wasn't about a full examination. I was really using this slide as a bit of a sort of a talking process, because the things that everyone does very well is spinal range of movement and spinal neurology. You all know how to examine that, and even my students know how to examine that. So I'm quite happy with that. And there are a number of special tests, and I'll go through the myelopathy ones in a minute, because those are the ones that tend to be not quite so well known, and everyone's good at palpating spines and areas. But the bit I wanted to focus on really was the last bit on the slide, which is associated areas, hips, knee, because the number of times I have seen people about to undergo surgery for a problem that is emanating from elsewhere. So recently there was a colleague of mine whose mother was about to have 3-level back surgery, and the problems in the hip wasn't in the back at all, and all they needed was a hip replacement, and lo and behold, their back pain disappeared. So just because there's pathology on the scan doesn't mean that it's got anything to do with their symptoms. So particularly for the back, beware of the sacroiliac joint, beware of the hip joints and the knee joints. They can all give you back pain. I had a lady recently who was complaining of right-sided back pain that came out of nowhere. And then I managed to drag it out of her that she'd actually had a hip replacement done recently, about a year ago, and that had upset her spinal balance because suddenly they'd lengthened her a little bit on one side. So again, don't just because the pain's in the back doesn't necessarily mean that's the area. Classic ones in the neck are, for example, shoulder problems. Often you'll get shoulder impingement. It can be very difficult to distinguish sometimes between pain in the shoulder and pain in the neck. They're so geographically close to each other. So one of the sort of fallacies I've seen over the years is when people have attributed the wrong part of the body as the cause of someone's symptoms. So examination, that was a bit that really I wanted to convey to the audience, that beware. We all get into the habit of pattern recognition. Someone gives us a good story, we see something we like on the neck, that's it. All the brain cells are connected, and there's your diagnosis. And we have to constantly question ourselves and check ourselves, because otherwise we'll miss things as you go along.
We had a question from Rachel related to what you were just saying, which you were talking about how the MRI may not indicate the true cause of the problem. She says, how do you handle how do you handle the patient's expectations and stop them catastrophizing when they are shown that there is a bulge or some other flaw in their MRI?
Yeah, it's a big problem. There are times I feel the first thing I need to do is surgically detach the MRI scan and report from the patient before we go forward. I had a patient who came in yesterday, and she said, "Do I do sacroiliac joint fusion?" Wow, what a conversation opener that is. And she'd had a scan done, and the scan suggested that she had problems, with some irritation in the sacroiliac joint. And 1 + 1 = 5,000, and she kind of got a bit carried away with herself. You need to spend time on that. So I will explain to them, first of all, as I think I may have put later in the talk, that there are a huge amount of people who've got various pathologies on their MRI scan and they're completely asymptomatic. What I teach my students is that the history examination and the MRI scan, they've got to line up. If they line up, then I think there's a good chance that what you're looking at the MRI scan may be responsible for some of their symptoms. But they often don't line up, and therefore it may be a red herring. But it's a big thing, detaching the report. I go through it with them. I tend to translate the report, because the report's often gobbledygook as well. So I tend to translate the report for them into everyday language. And I will go through the scan with them. I'll explain to I said I like teachers. I show them scans all the time in terms of what is what. And they can then see the degree of the problems. And usually, if you go through it in detail with you, they end up believing you that you've got some idea what you're talking about, and they tend to take notice of what you're saying. Yeah.
So facet syndrome.
I was just saying, put facet syndrome up, because I get so many patients who've absolutely decided they've got sciatica, and when usually they haven't. And to be honest, I see many more problems with their facet joints than I ever see with sciatica. So yes, of course you see sciatica, but I think it's a much less common condition. Of course, patients know a lot about sciatica, so they've all self-diagnosed themselves with sciatica. This, I suppose, was a bit more for my sort of medical students and surgical students, because they don't tend to see so much of this, but most of the audience, I would hope, in private practice do a lot more examination of the facet joints and the lumbar spine, and will be more than familiar with facet syndromes. But it was just to reinforce the fact that just because you've got pain in the back, and just because it's coming down towards the back of the knee, does not mean it is sciatica. But it's rarely the case. Classically, as you know, sciatica will most often be buttock and then below the knee into the calf and foot.
Right.
But that's all I really wanted to say.
Written at the bottom of your list of points.
Yeah, so we often ask them to crouch. You look for simple tests, and I ask them to crouch, and they often get what we call an extension catch on the way up. So you ask them to crouch, and they get up, and they start to feel it difficult. They often talk about it in their history. They find, what we call transitions, going from sort of lying to sitting, sitting to standing, are quite difficult. Once they're up and upright and motoring, it's a little bit easier. So these are evidences that the problem may be to do with the facets as much as to do with the nerves.
Yeah. Bob, this will intrigue a lot of people, because I think we always worry about the accuracy and the relevance, and so on, specificity and sensitivity of the special tests that we've got. Can you run through these for us?
Yes, of course. So the first thing to say is you're absolutely right. They aren't very specific. In fact, many people who've got myelopathy almost have none of the test. And so if you're trying to diagnose myelopathy, i.e. pressure on the spinal cord, then it's all in the history, okay? It's all in the history. It's lovely when the special tests confirm what you're thinking, but you don't often get them. Sperling's test is not really a test for myelopathy so much, although some people confuse it as such. It's when you press down on the head and you actually push the head to one side. And when you push the head to the side, it's the nerve on that side that tends to get infected, because its anatomical root becomes a little bit more elongated, and you get reproduction of pain coming down the arms. So that's a test of radicular pain. Lermity's sign is when you bend your neck forward, and when you put your neck forward, what tends to happen is it tends to cause compression on the spinal cord, and you get these electric shock signals coming up and down your spine. It's quite scary for the patient, and I have seen patients with it, but it's not a common thing. A wide-bade gaze is a much more common thing. You'll find, particularly with lower cervical myelopathies, that the neighbours think they're a bit drunk. They're sort of swaying a bit, and they've got to put their legs out a bit wider to get steady. And that's a classic sign of something's not right with your gait. So often they'll say that their stability and balance isn't quite right. Hoffman's sign is a sign of hyperreflexia. So when you get cord compression, reflexes, are sort of a sort of primitive cord reflexes. And so what you often do is if you take the patient's hand, if you like, and what you do is you sort of flick the terminal phalanx of the index finger, and you get a reflex contraction of the other fingers or middle finger. And that's really a sign of hyperreflexia. You'll see the same sort of thing when you're doing the reflexes. They all seem terribly exaggerated. And these are, if you like, they're sort of icings on the cake, if you like. They're nice if you get them. This certainly doesn't rule out myelopathy if you don't get them. So really, myelopathy is something that you'll come across in the history and look to be confirming with an MRI scan.
Well, I'm worried about asking questions because we've only got a quarter of an hour left and into this. But several people, I think 2, have asked whether you can clarify about facet joint pain. Because you said it's worse sitting than standing, and they're asking, do you mean that it's worse when they're moving between the 2 positions?
Yes. So with facet joint pain, typically when they're walking, it's not so bad. It's usually a problem that if they sit for any length of time, and there has to be a length of time in it, so they sometimes tend to get it after half an hour or so, and then it's when they change position. So when they change position, when they go from a sitting to a standing, that's when they feel it. Or if they've been lying down, they get up often first thing in the morning, they'll often find it stiff and sore. So it's a change of position that often gives them, because that's what the facet joints are involved in. They're involved in flexion extension of your spine. Once you're upright, actually you're moving about, you don't do so much flexion extension. It's more the sort of locomotor muscles of your hips that takes over. So it's not such a problem of walking. It's more of positions.
This is probably one that worries all osteopaths and chiropractors at some stage in their career, if not throughout their careers, isn't it? It's, are we going to miss a prolapsed disc?
Usually, fortunately, it's not so much of a problem. Most prolapsed discs get better by themselves. So if you're going to miss something, it's probably not a bad thing to do. I put this in because you're all in busy clinics and you don't really have time to do all the classical neurological tests that we all got taught in medical school. So we ask you to do some simple things. I find the slump test quite a useful thing. That's the one that's being demonstrated there, where they're sitting forward, and they're sort of bending their posture forward. That really stretches the old sciatic nerve out. What you're looking for, however, is a reproduction of the symptoms, okay? Because everyone, a lot of patients will have tight hamstrings. You're always going to get muscle pain, and they're going to say, well, it feels a bit tight at the back of the buttock of the thigh. That's not a positive test. What you're looking for is reproduction of the symptoms. So often, if you think they've got a prolapse, they're going to get some degree of tingling or shooting pain coming down into the lower leg, and you're looking to see that that gets reproduced. And if that gets reproduced, that's a positive test. Heel walking and tiptoes is very easy ways of testing nerves. So the common nerves that tend to get affected in the lumbar spine are L5 and S1. So when you're heel walking, that's forcing you to dorsiflex your ankle, and that's a test of L5. And when you're tiptoe walking, that's pressing down, that's testing S1. And crouching usually tests your quadriceps. So if you're looking for the common nerves that get affected, if you heel walk, you've tested L5. If you tiptoe walk, you've tested F1. If you've done a crouch, then you know that the L3 and L4, the quadriceps, is broadly speaking okay. These aren't going to pick up subtle differences, but I suppose from the point of view of surgery, you almost never operate for subtle differences. What you really want to know are their functional problems. You always remind your students that at the end of the day, the severity of the scans don't really matter much. What matters is their functional quality of life. If they can do these things, even if the disc looks big and the nerve looks horrible, I'm happy with that, because they can do what they need to do. So these functional tests we find a bit more useful than the sort of more didactic classical neurological tests.
Okay. So we move on.
So pitfalls of imaging I wanted to talk about. So X-rays are often the first thing that are done. And so traditionally, they used to be the first thing that were done, but actually we almost don't bother with them in spinal units up and down the country. One of the things that I would say is that if you're going to do an X-ray, well, what can you find? Well, sometimes you're doing it looking for alignment, and that's absolutely fine. Sometimes you're doing it looking for a fracture. It's not the most sensitive way of finding a fracture, but it's probably not a bad start if that's what you've got for. One thing it isn't good at is spotting cancers. But what you look for if you're going to look for a cancer is that most of the time, if you get a cancer in the spine, it goes to specific areas. It doesn't go randomly in the spine, and the area it typically goes to is the pedicle. And if you look on the diagram, I put it in the blue shadow. Those are the pedicles. They look like owl eyes, if you like. That's right there. And so if you look at the level above, you'll see that the owl eye is missing on the left-hand side where the red arrow is, and that is an indication of metastatic cancer or much more rarely a primary cancer in the pedicle. So it's always worth doing. You may well be looking for other things, but it's always worth just doing a sort of a rail, travel line, eye line check, just going down the pedicles to make sure you can see them all. Mm-hmm. Sadly, if you're looking for cancer, unfortunately, for a cancer to get to the stage where it's eaten away enough of the bone that you might actually see it on an X-ray, the cancer needs to eat a good 30 to 40% of the cortex. And with most cancers, sadly, early detection is really what you're after. So unfortunately, if you see it on an X-ray, it often means you're too late, I'm afraid. So you would never look for a cancer by an X-ray. That's not going to pick up the early signs. But if you're doing one for other reasons, it's well worth looking at.
Right.
If I can move on to MRI scans. Now, MRI scans, I think someone already mentioned, are the best source of information and the biggest bugbear that we have, because MRI scans do not tell you what is wrong, okay? That's a fundamental thing I tell my students again and again and again. So they're there to give you an idea of what is going on, but you have to work with it and the patient's examination history before you truly understand. Unfortunately, the sort of years of cost cutting, there are quite a few hospitals that are doing less than full scans. And when I mean scan as appropriate, I mean two things. So one is that you ought to have a full set of images, as I put at the bottom of the slide, because there are different images will give you different ideas of what's going on and help you look for different pathologies within the spine. But also make sure they've scanned the right bit, because they don't always do that, surprisingly. Sometimes, if you've got a patient who's got a pain in a particular area, ask the radiologist to put a little olive oil capsule on them before they go into the scanner, so you can actually correlate with the area that they're talking about when you actually look at the scan. If someone's had previous surgery, just please bear in mind that a usual MRI scan is of no use whatsoever. And the reason for that is that when you have surgery, you're going to get scar tissue inside, and scar tissue looks exactly the same as disc. If you look at the upper of the two pictures on the right hand side, you'll see that there's a black area just above and to the left of the spinal cord, which in most scans would look like a prolapsed disc. But actually this patient's had surgery, and if you look at the contrast scan on the picture below that, actually you can see the highlighted white signal around the nerve root. Scar tissue is very vascular, and when you give a contrast scan, the contrast goes into the circulation and highlights everything that has got lots of blood vessels in it. Disc, as you know, doesn't have blood vessels in it. So when it highlights up, it means it's scar tissue. So if they've had surgery, just be aware that a regular scan is not much use. You need a contrast enhanced scan.
Right.
Look to see who's done your report. Now, this is always a bit controversial, and I promise you that I've got lots of good friends who are radiologists. I love radiologists, okay? But often they've not got a clue what they're talking about when it comes to scans in the spine. So we may not get to it today, sadly, because of time, but I was going to show you a long list of missed diagnoses on scans, every single one of them missed by the radiologist. It's not their fault. Often they're done overseas. My own NHS trust outsourced all the radiology reports, and I'm afraid you get to know who they are. Once you've seen, we see 60, 70 scans a week, and you see the cut and paste that goes on. So let's put it this way, forget about me. There's not a single specialist up and down the country who would ever base anything on a report when it comes to MRI scans. That doesn't help you in terms of the audience very much, except to say for this. I'm a real believer that when you've seen patients for years and years and years, you get what I call your spidey sense, your sixth sense about when things are right and when things are wrong. Trust your judgment. Believe me, it's often more right than wrong. And sometimes if you look at the scan and it doesn't add up with what you're saying, trust your judgment. If you think something's not right and it isn't, get somebody else to have a look at it or get another scan or whatever. I'm telling you, more often than not, you'll be really glad that you did. But the reports themselves don't mean much to us. I can't do anything based on the report. I wouldn't base anything on that. So whenever I need to see it, I need to see the pictures themselves. So we always look to see who's reported it, and we'll always look to see the pictures. There are many, many things that are routinely missed, I'm afraid, on the scans.
Bob, given the time, I wonder if we might just jump ahead slightly, because as a sort of a warmer for this presentation, I sent out the infographic that's part of your presentation to everybody yesterday, and recommended people go to Dr. Fiona Dykes' site, Linda Dykes' site, to look at the things that she has on offer there. Cauda equina has been a little bit topical in our circles just recently. Could we go ahead and talk about that just for a few minutes before we close?
Sure. So a few things about cauda equina. So first of all, it is a clinical diagnosis, not a radiological one. Okay, and again, history and examination are the key things. Usually, the first sign of severe trouble is either problems with the urinary system or problems with a sensation. So although there's a long list of bits and pieces on this line here, I've detailed for you. I've actually put a few other slides that you might want to take home for your clinic.
Well, if you're happy, I've put this slide as a presentation, which I'll send out to everybody after.
Please do. Because I've put some slides in deliberately for you that you can sort of put up in places. But what you're looking for is the patients don't know that they need to empty their bladder, so they're sort of standing and suddenly pee's coming down their legs or whatever. So it's not that they sort of need to go quite often. Actually, that's not a bad sign, because at least they know they need to go. It's the not knowing they need to go usually is the first sign that you tend to get. Inability to control it often comes a little bit later, and sadly, loss of full bladder sensation, that's often when it is too late. So usually it's that sort of feeling that you just didn't know when you need to go in the bladder, that is often the first sign. Bowel functions come a little later, often when you got to the stage where your bowel's in trouble. I'm afraid it's usually too late. They may get sciatica bilaterally. And when they get sciatica bilaterally, again, often they start off with a large disc prolapse and that hits the nerves on both sides, and therefore they get sciatica down both sides. Saddle numbness and so forth, you know about. Those are the areas that you sit on, if you like, and you're often going to ask them if you're doing a video or remote consultation whether they can feel anything between their anus and their genitalia. But let me say this to you about cauda equina. As a consultant in the NHS, I expect to be referred lots and lots and lots of patients with query cauda equina who don't have it. Okay, that is what I expect. So I always sort of say to people, if you're worried, send it, because otherwise if that's that one, you miss it, it's a disaster. So I'm expecting, 15 times out of 16 that the patients you send into me won't have cord requirement, and that's fine, absolutely fine, because that is what we should be seeing. We should be seeing lots of negatives, because people will have these symptoms. They aren't very super specific symptoms. They are a little bit on the vague side. So if you're worried about it, please send it in. We will never get cross with you for sending it, because we're expecting you. It would be a worry for us if we were only ever seeing cord requirements when you referred in to us. But I would say that the three signs that really, amongst all of these things that you look at, saddle numbness, loss of the feeling that you are going to or know that you need to pass water, and the bilateral sciatica, I'd say probably are the three most important. Can I just, if it's all right, there was a slide there with a spinal stenosis on. I just wanted to say something, because often you guys will see a lot of scans in. If you look at that scan, this is a lateral side with the spine, and you can see the spinal cord coming down the middle, and then you suddenly see there's a blockage at the L4-5 level. Okay, and one of the questions I often get is, what is the difference between spinal stenosis, where there's significant compression of the spinal cord, and cauda equina? Okay, because on the scan they look the same. You look at that and you think that could be cauda equina, it could be spinal stenosis, which goes back to what I was saying, that cauda equina syndrome is a clinical diagnosis, not a radiological one. The difference between the two conditions is time. Okay, spinal stenosis is something that happens over the years, and as it sort of gradually worsens and worsens, and the spinal cord gets more and more compressed, the body has time to react to that, and because the body's got time to react to that, you don't get the symptoms of cauda equina. So you can squash the spinal cord, albeit slowly, to an eighth of its normal size. You still may not get any symptoms. Cauda equina is when suddenly you get a massive disc bulge that comes out from nowhere, hits the spinal cord, and it starts. That's when you get the classical symptoms of bilateral sciatica, saddle anesthesia, and urinary loss of sensation. So on the scans, they look the same. So it always comes down to a clinical diagnosis. You must, unfortunately, or if you don't want to do it, get one of us to do it if it's necessary. But we'll say to the medical students, if you do not put up the finger at the bottom to test their anal tone and sensation, that is a medically negligent event. Okay, and that's been shown in many legal cases go on. So we always say don't spare the finger. That may not be for you. You may not be comfortable with that, and we will happily do it for you. But you must test that if you're looking for it.
Bob, I always thank people like yourself for giving up their time for these shows, and I'm really sorry we haven't had time to cover everything that you had on there, but I did notice on one of the later slides you are inviting people to send people to you at 2:30 in the morning if they suspect cauda equina syndrome.
Yeah. No, I mean that. It's the only thing I'll get out of bed at 2:30 in the morning for. The reason for that is that time is critical. The clock starts when the urinary symptoms start. That's when your clock starts. Okay, and although you can look at the studies, if you take a straw poll from spinal surgeons across the country, if you had cauda equina as a spinal surgeon, which one of us would be happy to wait for 24 hours before their surgery? This was put up in our recent British Association of Spinal Surgery meeting last year in Brighton, and there wasn't a single hand that went up in the audience of 450 spinal surgeons. And that goes to show that, forget the studies, we all know the quicker you do it, the much better the outcome is. So if they've got cauda equina, I will operate at 2:30 in the morning, because it's a lifesaver.
A very quick last question, and this is the relevant case that I was thinking of when I mentioned this earlier on. Robin has asked whether you would refer for a suspected cauda equina problem if there were bladder symptoms, but they were intermittent, and the last one was only a week ago.
I would refer from it, but if the cauda equina started a week ago, it's probably too late to get any income. But when they've got incomplete symptoms, that's what there was an old classification called cauda equina incomplete. And when it's incomplete, you think there's something worth preserving. So you may stop it getting worse. You may not necessarily make it better. So the answer is yes, I would like you to refer it.
Yeah. Robin said that the symptoms of being unaware of bladder fullness and loss of control, and it's happened 3 times, but the most recent one was a week ago. This is following a fall down 7 steps in a flight, I believe.
So I would say that definitely needs a referral and a scan. I would say the urgency isn't there because it's obviously happened a week ago, and therefore usually if you're going to do something about it, you've got to do it within 48 hours. But the urgency is not there. But I do think that's positive neurology after a traumatic event. I think that needs referral and looking at.
Thank you for that. And when we were discussing this before, I also I had the discussion with Robin. It seemed to me that once you've written possible cauda equina syndrome in your notes, you'd jolly well better refer them, because otherwise that medico-legal problem might come back to bite you in the future.
Completely. If you're noting that in your records, then the next question will be, well, why didn't you act on it? And so in a funny kind of way, that's our job. It's our job is to take that nonsense off you. We may not like it, but that's our job. We pay a fortune for our indemnities, and we might as well get some good value out of it. So please burden us with that. That's our job.
Bob, thank you so much for your time. Would you be prepared perhaps to come back and finish off the presentation at some future date?
Yes, of course I would. I'd be delighted.
Brilliant. Thank you. We'll let you go for now.